I'd now like to hand over to Fernanda, who's going to moderate and chair the next session. Thank you.
Thank you very much, Karen. Very, very interested presentation. Thank you, Christian. The second session is going to be about what it means to live with Alpha-1. For those who might have joined later, my name is Fernanda. I'm the president of Alpha-1 Europe Alliance, and I'm also an Alpha-1 patient. That's it. For the next panel, we start with three speakers that I'm not sure if they need presentation, at least in the patient community. I think they are all very well known. They have been there for many years supporting patients and the Alpha-1 community. Still, I will do my best to introduce them. It's Marion, Karen, and Elena. I will start by introducing Marion. They will all tell us about their own patient stories. Marion was diagnosed with Alpha-1 before finding out that her children were carrier. At that time, then she turned to Alpha-1 Germany for information, and she quickly started working with them and became the president in 2015. Marion is also one of the patient representatives in EARCO. She was very much involved in the launching of the Alpha-1 Europe Alliance. She's always there for us. She's very knowledgeable, has a special touch with patients, and she is, well, she's great. I had the pleasure to meet her in Dublin, and I will give her the stage to talk to us about her story.
Thank you very much, Fernanda. Nice words for the beginning. And you told already my story, so I don't have to tell any more. No. Let me share the screen. Oops, can you see that? Can you see the screen now? Yeah. So yes. We just wanted to tell you some stories about what it meant to be being an Alpha-1 patient, but I think most of the persons in the chat and in the webinar will know already how it is to be a patient. And in my case, I'm 55 years old. I'm having 2 children, as you said, which are both carrier. Still, we always look at them because carrier, as Christian just said, are normally on the safe side, but we have to take care of them at least. So as a baby, I developed already a severe jaundice, so I was very yellow. And today we know that this is caused by Alpha-1 antitrypsin deficiency, but not at that time. So I initially had great difficulties to develop myself and had to spend a lot of time in university hospitals far away from my parents. So my youth was quite normal. So, but what does it mean to be normal in youth? So I had a lot of fun, like this flyer saying, I partied a lot. I also made a lot of sports, but unfortunately, I started smoking early on, and at least from 15 to 30, I smoked. So I had 15 pack years at that time. And one of my first diagnoses was at the age of 20. It was the asthma. So I had already problems with my lung and with my breathing, but I did not stop smoking. And later on I stopped, and the next diagnosis then was my Alpha-1 antitrypsin deficiency, which is BZZ. So I have a very, very low serum level, which means not much, which can protect my lung. And afterwards, I got some other diagnoses as well, so COPD, emphysema, and bronchiectasis. And the Alpha-1 diagnosis was a very hard blow. And I felt I had fallen a deep hole. I asked a lot of questions. Will I die soon? Would I manage to raise up my children? Or have I passed it also on to my children, as I know it is a genetic disease? And also the question, is this worth living when I have little air? Or is it hard living? How will I feel later on? There are thousands of questions when I got my diagnosis. Today, I must say I have very good, but also bad days. The weather has an influence, and also how I slept. The air is getting noticeably thinner, so my emphysema now has taken up to a quarter of my lungs. But I still can do almost everything I want to do. In many cases, slowly than before. I would say I have more cough due also to bronchiectasis. And fortunately, I have a good liver, but I also take care of it and go for regularly checkups. In Germany, we are currently having the best possible treatment options for AATD. The possibility of augmentation therapy and also options for rehab, lung training, lung sports, lung exercises, and physiotherapy. So we are very happy, and this should be standard in all over Europe, I would say. And one last slide for tomorrow. I think I have really accepted my disease and still live a happy life. But I have also hope, and this is what we hear later on the day. One day, researchers will find a drug that not only slows down the progression of the disease, but it will cure it, I hope. So I would like to hand it back to you, Fernanda. Thanks.
Thank you so much, Marion, for such a warm story and for giving us hope to those who are patients. I agree with you on your last message, and I'm also hopeful. I will now introduce Karen. Karen has been there for so many years already, so that I doubt she needs introduction, but I'll do my best. So she was diagnosed in 2005, and she has been playing a critical role in raising awareness on the condition. She is the chair of Alpha-1 UK, and she is a passionate advocate, I can tell you, at national and international levels. She is one of our most experienced members in the board of Alpha-1 Europe Alliance. She has been there since the beginning, and she took the role of secretary. We are grateful for that. And Karen's experience in patient groups is of great value for the Alliance, and she is also, together with Marion, a representative in EARCO, and she was also the driving force on the back of the European Alliance. So Karen, stage is yours.
Thank you so much, Fernanda. So I'm going to share my personal story of Alpha-1. So I was actually 15 years old when I was diagnosed with asthmatic hay fever, and that was predominantly due to severe shortness of breath. But any colds that I'd ever had, even as a child, caused really nasty chest infections. From the age of 15, I was treated with asthmatic inhalers for any exacerbations and my breathlessness, and also anti-allergy tablets during the summer months. And that's continued forever. But over the years, the use of my inhalers actually increased. My lung function gradually deteriorated. And it was around about when I was 40 years old that my new COPD nurse was actually really seriously concerned. I wasn't, but she was. And she said that statistically, my lungs were that of a 100-year-old. So she wanted to test me for something called Alpha-1 antitrypsin deficiency, purely because it had been raised on a course that she'd been on very recently. And she just wanted to rule it out because it was such a rare condition. I wasn't going to have that, but she just wanted to rule it out. So lo and behold, I received a positive diagnosis. And I said, well, okay, tell me about it. And she said, oh, well, I can't really tell you anything about it. I don't really know. But you're great at IT, you know, you work in IT. Go and research it on the internet. I'm like, okay, well, is there anyone you can refer me to? No, there aren't any experts either. Okay, so I went home and I sat at the computer and I did all my research. And I found out that alphas die within 5 years of their diagnosis. That was pretty devastating at 40 years old. And honestly, I had a lot of pity parties over the next few years. They did gradually diminish as I slowly came to terms with the diagnosis of the condition for which there was no cure, no treatment, or specialist clinicians. Thankfully, I found Alpha-1 UK and other alphas who supported me, which is predominantly why I'm involved with the group now. And that information proved to be untrue because I'm nearly 60 now, but my lung function has declined. It's categorized as severe obstruction, although it's been severe obstruction for so many years, I can't remember how many. So that's just proof that you can live with severe obstruction for quite a long time. But I now have to use oxygen for any tasks that require exertion. And that means not running marathons. That means getting dressed, getting undressed, doing the shopping, doing housework, climbing the stairs, walking the dog. Walking anything more than 20 meters without oxygen is impossible. So I think, like most of the alphas who are here, I avoid anybody who's got a simple cold. I've done that for the last 20 years because a cold can completely incapacitate me. Walking and talking at the same time, that's something that I've long forgotten that I used to be able to do. And during a recent respiratory infection, I found even making toast in the toaster or walking 6 meters indoors left me totally out of breath. And it used to take about 6 weeks to recover from a chest infection. It's now probably 10 plus before I get back to my normal. So I know I've got to stay active. So I walk my dog most days if I can. And I do walk in most days myself. However, some days, if the weather's not quite great or it's too humid, it takes me a lot longer and I maybe don't walk as far. So absolutely everything that non-alphas take for granted, getting dressed, putting your coat or your shoes on, rushing to answer the door or the telephone, it takes a heck of a lot longer. And when I get there, I can't breathe, so I can't talk. So that's always quite interesting. Hopefully they know me. So since my diagnosis, I'd say life has changed quite significantly. So whilst the numbers of my lung function tests have remained actually pretty stable over these last 20 years, that doesn't mean my health hasn't deteriorated. And neither does it mean that my physical capabilities haven't severely diminished, because they have. So the majority of my hobbies are all distant memories. So dancing the night away, water skiing, scuba diving, snorkeling, they all disappeared really many, many years ago now. But I've always loved to host dinner parties. But that's now even becoming quite exhausting. And preparing more than one course actually needs careful planning. And I have to opt for cooking easier options, not the extravagant meals that I would probably have prepared historically. Days out to go shopping, or just shopping trips, just to the supermarket. If it's anywhere I don't know, I have to plan that meticulously. Where will I park? Are there going to be any hills, stairs, lifts? How much oxygen will I need to take with me? Do I need extra batteries? It all takes extra energy. And packing the car up for a holiday, yeah, that's like a marathon. So even with all of that, I still think I'm actually one of the lucky ones. There are other alphas much younger than me who are incapacitated, who require daily care and assistance with everyday tasks. They can't cook. Some have already received lung or liver transplants, and many have sadly died. So life isn't always easy, but we do have to see the positive things in our lives and celebrate the things that we can do, not what we can't. So we need to stay as active and as healthy as we can, advocate for Alpha-1 awareness, and hope that that cure is on the horizon. Thanks. Back to you, Fernanda.
Thanks a lot, Karen, for your story. I can relate to many parts of it, and seeing the amount of hearts I was seeing here and there, I know many people in the audience will be relating to a lot of it. But I take one of your last message, let's celebrate and focus on what we can do, and let's continue to advocate. So thank you very much, Karen. I'm now going to introduce the last person in the panel. What can I say about Elena? First of all, that we share not only nationality, we are both Spanish, but on top of, we discovered that we are both from the same region. And when I go back to Spain, we try to meet. It's not always easy, but we try to meet each other. And it's nice also to be able to speak to somebody in your mother language about your disease in this international context. Elena's experience is as a wife and a mother of people living with Alpha-1. And once she realized that, she quickly reached out to the Spanish Alpha-1 Patient Association, where she is now the vice president, but she is also much more. I've been in Spain in one of the events she has organized, and you can see that she is really the driver, or one of the key drivers behind the Spanish organization. And it's not only that, her contribution as a volunteer for Spain, but also for the European Alliance, is key. She's a really hard worker, and she is, we're really happy to, at least I'm very happy to have her in the board of the Europe Alliance. So Elena, really looking forward to hearing your story.
Thank you very much, Fernanda. Our story, our family story, because it's the story of a complete family, began with when my husband was diagnosed with Alpha-1, but it was 6 years after he was first diagnosed with COPD, when he had already lost over 60% of his lung capacity. He had been diagnosed with emphysema and bronchiectasis at 48. He had smoked for a few years when he was young, but had quit almost 20 years earlier. Today I know that he was a clear candidate for Alpha-1 testing from the very, very beginning. His diagnosis led to a family study, which explains some symptoms of 2 of our 3 children, who were then 4-year-old twins. They are Z and SZ. The ZZ boy had growth issues and vitamin deficiencies from birth. He was always sick, underweight, and had regularly high transaminases that several pediatricians attributed to frequent respiratory infections. At that point, I began investigating about Alpha-1 and reached out to the Spanish Alpha-1 Patient Association. They told us about the augmentation therapy for my husband, which he could start 3 months later, fortunately. And after many efforts, we also managed to get the boys referred to a pediatric pulmonologist. As the SZ twin had also frequent respiratory symptoms, we were lucky that he knew about Alpha-1. He diagnosed both twins with asthma and monitored them every 6 months until they moved to adult pulmonologists. He also gave us a clear action plan for managing infections or exacerbations, which gave us really a peace of mind because we knew what to do in every case. The ZZ twin asthma has improved as he grew, but the SZ boy developed significant respiratory allergies. And today he continues with his treatment and has his asthma, fortunately, under control. In parallel, we managed to get the ZZ boy referred to a children's hospital with hepatologists, experts in Alpha-1, about 500 kilometers away from us, from where we live in Madrid. From the age of 4 to 17, we travel to Madrid every 6 months to monitor his growth and liver condition. For a few years, the reality is that we felt a sense of calm facing illness, but learning to live with Alpha-1, but knowing always that everyone was getting the best care, the best possible care. But recently, our ZZ son, already 18, was hospitalized for a severe pneumonia. We were told that the scans showed trapped air, indicating early signs of emphysema. However, his functional tests are excellent, and we hope his next scan will show clear lungs. In that phase, what I learned is that very few describe a case lung disease can also begin in adolescents. Today, they are university students living normal lives. They exercise regularly, they get vaccinated, and as far as I know, they don't drink alcohol and they eat healthy. They've learned to manage their health and don't ignore any respiratory infection that takes too long to solve or to heal. They are monitored in pulmonology and hepatology, and the ZZ lab liver results sometimes are almost perfect, and on other times the transaminases remain much elevated for months. From my experience, family testing is essential, and I believe there is still a lot to be done for pediatricians to know more about Alpha-1 so that can recognize symptoms and take preventive actions. It is true that identifying children, alpha children, puts pressure, much pressure on families, but it allows us to manage risk as monitoring, controlling infections, teaching them healthy habits, and ensuring they will not work in jobs that can put their health at risk in the future. Today in Spain, I believe that more children are diagnosed with Alpha-1, but pediatricians still tell families that Alpha-1 isn't a deal and that avoiding smoking is enough. I know that smoking is crucial, but I believe there are many other things that we can do to reduce risks. As parents, worrying and trying to stay ahead of problems is part of our role. But I really hope that the situation improves and that more pediatric healthcare for professionals are prepared to support families to provide information and to implement preventive measures, simple step that could prevent much illness and much suffering. Thank you.
Thanks a lot, Elena, for this warm message of a mother that really is a true carer. And not only for your children, I know you care a lot about all your patients. I do agree with you so much about the importance of the family testing and the importance of having an early diagnosis, because there is a lot we can do, a lot much more than, like you say, like smoking. So thanks a lot for your message and for your story.
Thank you.
We are moving now to the second part of the panel, where we have experts that are going to talk about something that is very important as well. It's about the management of the disease, of a chronic disease, but also about the impact on our mental health. Our first panelist is Paul Kobler. Paul is a psychologist and a psychotherapist working at the Nuremberg General Hospital in Germany. And his years of experience working with lung patients has given him an understanding of how living with a lung condition can affect mental health. Paul, the stage is yours.
Thank you. I just want to try to share my screen with you. I hope you can see it. All right. Okay. Yes, thank you for the lovely introduction. At first, yeah, I'm working in the Nuremberg Hospital in Germany, and there we do a lot of integrated care. That means we try to support patients with chronic, with severe somatic diseases, such as lung diseases, in terms of their mental health and their well-being. And I'm glad to speak today with you about mental health, psyche, and breathing. And first of all, I just want to thank my previous speakers just for sharing their touching experiences with us. So I think, of course, you are the experts regarding this topic, in my opinion. And in my talk now, I just want to maybe highlight or add some points from the clinical perspective. So first of all, let me see. Okay. So talking about psyche and Alpha-1 or ATD, so what do we know about it? Today I will try to focus on scientific research, which in my understanding reflects our experiences in the clinical care with patients with somatic diseases, and hopefully with your experience as patients or as relatives of patients as well. There is a review on effects of Alpha-1 on the lives of patients from Bacon Strange. And they summarize many of the issues you already talked about. So they say, of course, the many patients suffer from the reduced capacity, from limitations in everyday life. They suffer from fears about the future because the course of their disease is unpredictable, and they are not sure what the next years and the next months sometimes will bring them. Many of them have some financial issues as well due to their reduced capacity, so they can't work in the way they were used to. They, of course, that we heard about as well, and suffer from concerns about the genetic transmission of the disease. And this is really important, and we heard about that as well. Many patients with Alpha-1 have a long way of suffering before they're getting the right diagnosis, because there's still a lack of awareness in the care system of the disease. And from a psychological perspective, an additional finding, which is stated in a lots of research in the field, especially regarding chronic diseases and lung diseases, is that the quality of life from patients is only indirectly related to physical condition such as lung function. So the much more important factor is the mental stress, which predicts quality of life. So what numbers do we have regarding the mental stress in terms of syndromes in Alpha-1? So I bring just two examples from the literature for you about AATD and mental distress. So to estimate the share of mental burden in clinical relevant syndromes, you see it's between 16%, it's in Mobin et al. At 2021 and 31% in Greulich et al. Which is a really interesting study from Germany with 2.8 million people, including all the insurance data, and they focused here on AATD as well, and they figured out 31% of depressive patients in AATD. So we can say mental distress, especially anxiety and depression, is an important issue for chronic somatic disorders like Alpha-1, and that's what my further talk is about. So let's try to go do a deeper dive in this issue. Here in this publication, it's called Relationship Between Depression and Anxiety, Health Status and Lung Function in Patients with Alpha-1. They included 840 patients roundabout with AATD in the UK over 20 years, and they focused on mental health and lung function on the long run with multiple data points, which is quite interesting. So what they suggest in their paper gives us a good framework regarding psyche and Alpha-1. First of all, they call the health system, the primary care, the doctors, but also, of course, the patients. It is really important to constantly monitor mental health, which means we know that there's a high prevalence, as I told you before, and that we have a significant impact from mental distress on quality of life. So we do actively need to monitor mental health in the context in primary care, for example. And secondly, in the paper, they call for what they call a holistic treatment approach. It means like to see the patient in a whole, to integrate psychological assessments, psychological treatments into the care plans for AATD patients and to improve their overall health outcomes. And this is a really important issue because in many cases in terms of many somatic diseases, we are not fitting this point perfectly in our treatment. So this is an issue for the whole, care system to integrate psychological treatments as well. But let us do a more deeper dive to more specifically what can we do from the health system. So their work here suggests mainly three big fields to address mental health in AATD and lung function. And again, this is what our clinical experience reflects as well. The first one they emphasize in their paper is the importance of education and rehabilitation. So gaining knowledge, actively deal with the disease, networking with experts, other patients. This seems to be one of the biggest factors in coping with Alpha-1 and with the mental stress. And therefore, of course, I want to appreciate the possibility of today, the conference and your participation in the conference, because of course, this is what the point is about. So you're doing a great job for your mental well-being, attending here and sharing your knowledge with the others. The second pillar, if you want to put it in that way, is CBT. CBT means cognitive behavioral therapy. And you will find this term in the literature for mental well-being in terms of chronic somatic diseases everywhere. So it's an umbrella term which is widely which means widely accepted and proved psychotherapy method. And when you go in Germany, or I guess in UK and other countries in Europe, it will be the same. You will go to a psychotherapist. It's probably the most widely used therapy. So if you go to a therapist, there's a high probability that he will offer techniques from CBT to you. We will today not make it to go deeper in it, but you can think about it, or you can try to understand it like it comes from learning psychology and from behavior psychology, and means like therapy often confrontates you with your sorrows, with your anxiety, with your thoughts, questioning maybe your burdening thoughts that you have, confronting you with your sorrows. And another really important issue is to train and to try to learn some pacing, which means you're getting in touch with your capacity step by step, trying to expand it a bit. The third pillar of mental well-being in terms of lung function in Alpha-1 is called relaxation and mindfulness. So it's the umbrella term as well. And the many techniques they suggest in the literature, and which is our clinical experience as well, regard relaxation techniques like PMR or autogenic training. You can improve your anxiety, you can improve your relaxation capability, but even your depression and your physical performance doing this regularly. There are some good studies in COPD with Qigong, with Tai Chi, with yoga, which all of them include mindfulness and relaxation in both terms. One main statement in this paper I talked about the last minutes, I want to highlight besides because I think it's really important for the next minutes. So they write in the patient cohort, depression and anxiety was linked to a greater decline in FEV1, which means the lung function, as you probably all know. So how can we understand this kind of relationship? And this is really interesting for me because this is what a psychosomatic approach is about. So dealing with interactions between mind and body. In the next minutes, I will show you a model which summarizes a couple of this interaction regarding the lung function and breathlessness. It's called the breathing, thinking, functioning model, published first from Spethis in 2017. And it's a model which, as you can see here, states different kinds of vicious circles regarding dyspnea and breathlessness. This is, by the way, exactly what we do with our patients in the hospital, like educate them, showing them this kind of interactions, understanding them, and trying to find a way out with them. What is, by the way, is typically a part of the CBT therapy as well. So let us see how we can understand this kind of interactions. The first one is a breathing vicious circle. And you see here that it means that more or less, sorry, the breathlessness leads to, of course, increased respiratory rate. You're doing a lot of work breathing, but the breathing seems to be inefficient. So you do a more inefficient breathing. It's more exhaustive for you, and this leads to more breathlessness, which causes more respiratory work and so on. So this is a vicious circle, and the authors suggest a couple of management approaches to finding a way slightly out, which of course means training it. So they suggest some breathing techniques you maybe all know. So they suggest, for example, breathing techniques, calming you down with a sufficiently breathing. I will show you an example with how they advise the doctors to talk with the patients about that. In times of breathlessness, it can help to use a handheld fan, for example. So studies have shown that a stream of cold air into the face can alleviate the feeling of breathlessness a bit. Of course, the muscle training for the inspiratory muscles, and if it's possible or if you need it, non-invasive ventilation. This paper I'm talking about right now also makes suggestions how to come in contact with patients with breathlessness in terms of lung diseases. Um, when you are a professional, when you're a doctor or a therapist, to invite them to think about it. And I think this was quite interesting. So I just bring it with me and I will read it for you. So they suggest kind of approach to talk like it is a natural to think when you're feeling breathless that you need more air in, but in fact, this isn't the case. We know that there's plenty of air in your lungs, and I try instead to lengthen your out breath, which can make your breathing more efficient and create space for your next breath. Let us go to the second vicious circle, which is about the thinking in the breathlessness. So we see here in the thinking that breathlessness causes threatening thoughts about suffocation, about death, about catastrophic experiences, and this leads to maybe higher attention to your unpleasant sensations. It leads to anxiety, to distress, which causes breathlessness and which leads to more panicking and to more threatening thoughts. So this is a vicious circle as well. The symptom management approaches the authors introduce are things we already know from the slides before. So they emphasize the importance of cognitive behavioral therapy, of relaxation techniques, and mindfulness techniques. And it's the mindfulness, maybe just one sentence about that. It means like observing your thoughts without getting too much in touch with that, and getting a distance to the threatening thoughts as well. So it's a kind of technique you can train in the therapy or with apps. And in the next sentence I show you, you will see how the confrontation with threatening thoughts and maybe our CBT will work, because confrontation with thoughts which frighten us could in the long term make possible to cope with it in a better way. So they have here this example. They say some people say that they're terrified, that they are going to die gasping for breath. Although this is an understandable feeling, this almost never happens. At that time, waste gases tend to build up in the blood, making people feel calm and sleepy. So you might think this is really harsh and hard. And of course, it should be embedded in empathic contact between patient and doctor, but it can be helpful to confrontate people in their pace, of course, with their threatening thoughts to getting a better management. The last vicious circle I want to show you is the functioning vicious circle in breathlessness. We see here that breathlessness, of course, is many times reduced activity because we cannot have not the capacity to do everything like before, and there's a tendency to isolate ourselves and getting more help, which causes lower capacity because we're not training that much more. So it's leading to a deconditioning of the muscles, which of course can lead to more breathlessness due to a reduced capacity, which causes reduced activity. And this is another vicious circle. So the authors suggest here, of course, a pulmonary rehabilitation to train to do pacing, which means to train your capacity in small steps, and if you need it, maybe to train with aids or to move with aids is better than not to move or not to train at all. Here they had this example from a doctor that talking to the patient, like choosing to make yourself moderately breathless by being active is not harming you. In fact, it builds up fitness in your muscles again and can improve your breathing and general health over weeks and months. Let me come to the last point I want to highlight today with you because I think it's so important. It's about the distress of relatives. Relatives of patients with Alpha-1 are highly affected by the diseases of the loved ones and as well. And therefore, we should not only look at the patients, but at the whole systems of families which are highly affected by chronic diseases because all of them carry burden of the disease as well. Just a review on disease burden of ATD patients and their relatives. I just summarize a couple of points here, and you see it's kind of the same like for the patients as well. So the loss of flexibility, opportunities in their lives, so financial problems. They suffer from loneliness, from reduced participation because of the care work, for example, and they often suffer from anxiety, stress, and feelings of despair as well due to the worries about the sick family member, and sometimes, of course, of feelings of guilt as well. We know from a clinical impressions and empirical work with family members of sick patients like this from Creamer and Bengel in 2016, that a coping, which they call joint active coping, means better mental health for the whole system. And this means, of course, actively and consciously dealing with the illness, doing things together, going together to the doctors, activating your social resources, asking for help, asking for advice, giving advice as well, networking. So going together to the conference today, for example, is a really good example for doing that, and it's associated with more mental stability compared to passive or resigned coping. Sorensen did a meta-analysis with intervention studies with family caregivers, and they see the same thing I was talking about in the last minutes, like psycho-educational interventions, getting information together, maybe doing some training together, communicate about your anxiety and your sorrows with your loved ones, can hold you. And this is what we do today, I think, and you're doing a great job in doing so, and I'm really glad to have a couple of minutes to speak about that. And I'm excited about maybe your questions, if you have some, and try to answer that, of course. Thank you for your attention.
Thank you very much, Paul, for your very interesting presentation. I think it's a very important topic for us patients. I do myself practice mindfulness, and it helps me. And it has also helped me, for example, to meet other people and be able to openly discuss about it with people who are living in the same situation. So thank you very much, and for all the tips you have been giving us in terms of the techniques that we can use. Before going to the questions that I hope we will get for you, Paul, I'm going to present our last panelist for today. Our last panelist is Nicole Hopkins. Nicole has lived with chronic lung conditions throughout her life, and after gaining a master's degree in long-term and chronic condition management, she understands the hurdles that people living with chronic conditions face, and she's going to tell us today about it. So, welcome, Nicole. The stage is yours.
Hello, good morning or good afternoon, depending where you are around the world. So my name is Nicole. I've been invited here to be with you today by Karen. I've met Karen 4 years ago. It's been a long story of exercise. So what I'm going to do, I'm going to give it a bit of exercise. So it's going to put ex practice everything that Mr. Kobler just said. I'm going to play some music. You don't have to follow the music. You don't have to follow me. And you probably all done some pulmonary rehabilitation. So don't forget to use your pursed lip breathing while we do the exercise session. So is everybody ready? Great. So let me play some music and just have fun. Keep smiling. It's the best way to exercise is to keep smiling. Here we go. So, let's start marching on the spot. Remember, you're in charge. If you prefer to do the exercise sitting down, please do so. Okay, let's do some toe tapping forward. And march. Heel digs. Keep marching. Some knee raises. And march. Feet wider apart. Hamstring curl. And march. Toe tapping sideways. And march. Remember, keep smiling, it makes it so much easier. Toe tapping backwards. And march. Okay, we're going to add some upper body movement. Here we go. Toe tapping forward and bicep curl. And march. Heel digs and pec deck. And march. Knee raises. And march. Feet wider apart. Hamstring curl and pull. and march. Side step toe tap and lateral raise. And march. Keep moving. Toe tapping backwards and upright row. And march. Okay, we're going to stretch the leg. Let's start with the hamstring. 1 foot forward, sit back, lift the toes. And march. Change side. And march. Next the calf, 1 step backwards, push the upper body forward. And march. Change side. And march. Next we're going to stretch the quads. If you need to hold yourself somewhere, please do so. You can grab your ankle, your trousers. You can also move the leg forward and back from the knee if it's easier for you. And march. Change side. And march. Feet wider apart, knees slightly bent, arm in front of you. We're going to swing side to side from the waist. Last one, face forward again and march. Here we go again, toe tapping forward and bicep curl. And march. Heel digs and upright row. And march. Knee raises. And march. Feet wider apart. Hamstring curl and pull. And march. Side step toe tap and lateral raise. And march. toe tapping backwards and frontal raise. And march. Okay, while marching, we're going to stretch the upper body. Let's start with the shoulder. Change side. Next, the tricep, hand on the shoulder, push the elbow back. Change side. Both arms down. Next, we're going to do the back. Push the hand forward, chin down. Bring the arm down slowly. Open your chest and behind the lower back. Push your chest forward. And march. Don't worry, this is the last round. Here we go again. Toe tapping forward and bicep curl. And march. Heel digs and upward roll. And march. Knee raises. And march. Feet wider apart. Hamstring curl. And march. Side step toe tap. And march. We're going to slow down. Slow down. Focus on your breathing. Keep smiling, I hope. Okay, so feet wider apart. We're going to do a couple of breathing exercises. So knee slightly bent, your bum goes back to start, arm lateral raise. We're going to exhale, don't go too low, inhale, and again, exhale, inhale, couple more, exhale, inhale, last one, exhale, inhale, hands together, feet together, bring the arm down slowly. Well done, everybody. I'm sure you were all fantastic. Fantastic. Thank you for having me.
Thank you so much, Nicole.
You're most welcome. Thank you for
Thank
having
you.
me, and I hope the day goes well for everybody.
It was a very energizing session. I loved your enthusiasm. I love the
Thank you.
music and your recommendation to keep smiling. Thank you so much.
Perfect. Thank you very much. Take care, everybody. Bye.
Okay, we have come to the end of the panel, and I see the panelists joining back to reply to some of the questions that we have been getting. I see one for Dr. Kobler. I'm going to read it, Paul. So, has any work been done on the prevalence specifically of claustrophobic feelings related to breathlessness and worsening lung function? Even reading things in the news can freak me out nowadays. I wasn't bothered in the same way in the past.
Thank you for the questions. Yes, I was doing a little research, and meanwhile, I couldn't find any specific studies on the exact prevalence of claustrophobic or claustrophobia. But still, we can assume claustrophobia, of course, is often associated with anxiety and panic, of course. It can increase feelings of breathlessness, of course, and this is a common symptom in patients with impaired lung function, of course. So I would say the link maybe is often an indirect one, like, as I try to figure out with you. So that means anxiety sometimes leads to panic and feelings of anxiety, and therefore breathing problems, and these can lead, for example, to reduce the activity, to isolate yourself, which affects the lung function then. So there is a vicious circle kind of. And oops, I just lost my phone. Reading the news, I thought about that issue as well. Yeah, reading the news nowadays is often not very calming, right? So sometimes I think try to do a little detachment from the things in the world around that we can't change can help. We call that mental hygiene, or like, caring for yourself. I think it's an important issue for all of us, but especially if you're suffering from chronic disease and impaired lung function as well. So yes.
Thank you, Paul, for your answer. I see one in the chat that is to hear from other ZZs, said. So perhaps Marion or Karen or both, you want to give us your perspective if there are alternative treatments. The question talks about acupuncture, massage, or any breathing guidance from a yoga point of view. Any experience on that one? Do you use other alternative treatments?
Maybe I can start. Yes, everything what is good for your well-being is also good for the disease. So if the massage is helping, and especially the massage is something I personally like to have that, because it helps also to bring the sputum out of me. So this is something where help is really good, I think, and also alternative things in any case, in any sport, for mental health, for the psyche, everything which is good for you and for your positive feeling is also good for the disease. Karen may add something.
So I think many years ago, when I did my very, very first pulmonary rehab course in Scotland, and they do a number of sessions on well-being and whatever. So I remember the instructor saying to me, "Okay, Karen, you'll do this really well." She said, "Take a deep breath in," and I did. And she said, "Excellent," and I went. And she meant excellent for showing the wrong way to be breathing rather than the right way to be breathing. But my diaphragm didn't work, so I had to retrain my diaphragm to actually start working. And I know Christian mentioned this earlier, and Paul also mentioned the fact that, when you're breathing it's not the in-breath you need to concentrate on, it's the out-breath. So, you know, during the exercise session, and Nicole does a class for the UK, Alpha-1 UK, every Wednesday evening, and we concentrate on blowing out. So even if I'm in a severe breathlessness situation, I really try and use mindfulness breathing to ensure that I'm blowing out more than I'm breathing in, because my body's naturally going to breathe in, but it doesn't naturally force the breath out when you're breathless. And retraining your diaphragm to work, mine's not great these days, but trying to use your diaphragm so that you're breathing down deeper into your lungs helps you get up the stairs. Staying fit, it's your muscles that get you up the stairs, not your lungs. So stay fit.
So maybe I may add some to Karen's comment. It's just simple. I just recovered from COVID, so therefore it is also a good exercise to do that. Just breathe in for 3 seconds and breath out for 10 seconds. As much as you can. If not 10, then 9, 8, whatever. But try to do more each time you do that. That helps the phlegm brings out as well as your condition. So for COVID patients as well as for Alpha-1 patients and every lung patients, I guess.
10 seconds is a bit optimistic.
Yeah.
However, doing something like square breathing, so you're concentrating on the 4 corners of a door or a window, can help you concentrate on something else other than the breathing. And if you can blow out just fractionally longer than the in, you'll eventually get much more relief from your breathlessness episode.
Mm.
Thanks a lot, Karen and Marion, for your perspectives. For me personally, for example, I use breathing together with mindfulness. So I use the mindfulness breathing techniques, and that helps both with the lungs and with the mental aspect that Paul was talking about. So that would be one to add. I saw that Elena also got a question that she has answered through the chat, but perhaps Elena, you don't mind to tell for everyone in case they haven't seen your answer. It's about what do you say to your sons regarding, well, what do you tell your sons about the next generation? What do you tell the next generation? Probably there are a lot of carers in the audience, so.
What I usually say is that I really trust in the cure, and I hope they will get the cure before developing serious illness. But I know when I teach them about the genetic counseling, I think it's important for them to contact and to know what is Alpha-1 before they create their new family. They are 18 and 24 now because I have 3 children. But it's a good thing to know about the genetic transmission of Alpha-1 and to take it in account when they have children, in case they have, because we don't know right now. But I trust the cure, and I say to all the parents I meet in our association, because I think it's near. Maybe I'm too enthusiastic, but I believe it's near.
Thank you so much for that.
Sorry, Fernanda.
Yes.
Somebody commented in the actual webinar chat about singing for lung health and a harmonica for lung health.
Okay.
Anything like that is going to be beneficial. If you're me, you might want to do the singing in the car or the shower where you're not going to torture somebody's ears. But yeah, singing, playing harmonica, anything that's going to exercise those lungs is great.
May I just add, there's a couple of publications about that as well. There's a kind of concept they call singing for lung health, SLH. It seems to be a good training, and of course it's good for your mental distress as well. So you have the combination of both of it. It reduces stress and increases your capability for briefing to training. This is really helpful.
Any other comments, thoughts on the questions that we have seen on the chat before we close? I think we need to go to the break. Okay, so thank you all for your insights and your stories. And we're going now for a 5-minute break, if I'm not mistaken.
25. Back
20.
at 1.
Sorry, we are back at 1 for the UK, 12 for people
12
in.
for the UK, 1 for Europe.
Sorry, thank you, Karen. Thank you all.
Thank you.
Thanks, Fernanda.